Hi, this is Michael Altos, and we are finishing up our section on anesthesia and the endocrine system based on Barish chapter 46, and this is part 4. So now we're going to speak about diabetes. Diabetes can be defined as a fasting blood glucose of above 126 milligrams per deciliter. And usually those measurements need to be taken over a course of a period of weeks or months, I believe, before you can actually diagnose diabetes. Patients can also fall into the pre-diabetic or impaired range, whereas normal should really be a fasting blood glucose of below 100. Diabetes is broken down into type 1 and type 2. Type 1 is always insulin-dependent diabetes, previously known as juvenile or early onset diabetes, and is associated with diabetic ketoacidosis. The mechanism is believed to be autoimmune, and it's an absolute insulin deficiency where pancreatic beta cells no longer produce any insulin due to, we believe, an autoimmune attack on those cells. Type 2 diabetes, often called non-insulin dependent diabetes or adult or late onset diabetes, although we will see that these are not always correct. And type 2 diabetes is more commonly associated with the hyperosmotic non-ketotic coma. This usually starts out as a relative insulin deficiency or insulin resistance. Let's speak for just a few minutes about insulin. Insulin is a peptide that is synthesized in the pancreatic beta cells. Some of the primary functions of insulin include facilitating transport of glucose and also potassium into the cells. Insulin is a hormone that shifts your metabolism towards storage. That would be synthesis of glycogen, lipid synthesis, and protein synthesis, which means that insulin is an anabolic hormone. Your pancreas secretes insulin at a rate of about 1 unit per hour at rest. But in addition to that, your body secretes a total of about 40 to 50 units a day in response to food and stress. Cortisol, catecholamines, glucagon, and growth hormone all can lead to hyperglycemia, and insulin will have to be secreted in response to these. Alpha stimulation seems to decrease insulin and increase glucagon, whereas beta stimulation and parasympathetic stimulation increase insulin levels. Now, one thing a lot of people don't understand is the best way to administer exogenous insulin. The insulin receptor is really designed to work best at low insulin concentrations, and we see this often in the operating room or in the ICU when treating a patient with hyperglycemia with insulin boluses and infusion. We will find that running an infusion of just 1 to 2 units per hour continuously can be much more effective than giving multiple large boluses. Now, we do appreciate that large boluses do take longer to clear than small boluses, so there may be a greater net effect from a large bolus than a small bolus, but often a continuous infusion is the most physiologic way to manage hyperglycemia. Insulin is metabolized in the kidneys and the liver with a half time of only 5 to 10 minutes, but the sustained effect of insulin is closer to the 30 to 60 minute range, and that's because insulin is so tightly bound to receptors. When using exogenous insulin, it's important to remember for boards questions as well as clinical practice that the biggest risk is hypoglycemia. And as your goals for blood glucose control become tighter and tighter, this risk increases. In patients who have insulin resistance, that would be type 2 diabetics, we may find that they need more and more insulin in order to achieve a given effect. In the preoperative period, we usually instruct patients to take none of their short-acting insulin on the day of surgery, and to take a reduced, perhaps a half dose of their long-acting insulin. Patients who have implanted insulin pumps have a choice of discontinuing the pump or placing the pump on a continuous infusion. The most important thing is for us to be clear on what insulin is on board and continuing to be given to this patient during the perioperative period. And I think for longer cases, it's usually common to just discontinue the pump altogether. Intraoperatively, we usually employ a sliding scale in order to manage hyperglycemia. The best way to do this is with a protocol, and our institution has published protocols, one of which I've reproduced in your notes. In a normal patient, 1 unit of regular insulin will lower your plasma glucose by about 25 to 30 milligrams per deciliter, with an onset of about 10 minutes for a bolus of IV insulin, peak action in 15 to 30 minutes, and a duration, as we said before, of about 30 to 60 minutes. An insulin infusion can be run. The simplest way is just to start at 0.1 units per kilogram per hour. Others calculate a starting infusion by taking the plasma glucose and dividing it by 150. Remember that insulin can actually be absorbed by the plastic tubing, and the recommendation is to run through the first 20 milliliters of insulin fluid through the tubing and into the garbage. Here's an example of an insulin sliding scale. It has 2 parts. First, it has an initiation phase where we find the patient's blood glucose and then give the appropriate bolus and start an insulin infusion. Subsequently, we check blood glucose every hour, and the 2 things we want to know are what the new blood glucose is and whether the blood glucose has decreased by at least 30 milligrams per deciliter, or whether it decreased by less than 30 or even increased. And then based on that information, we can find the patient's new blood sugar, whether the rate decreased by a lot, the new blood glucose decreased by a lot or a little bit, and then use that information to determine what to do next. This chart just reminds us that there are several different insulin preparations. Some of them include Lispro, which is a very short-acting insulin. And I want to draw your attention that this is talking about subcutaneous administration, so the numbers are a little different than for IV administration. Going on to regular, long-acting or NPH insulin, and even Glargine or Lantus insulin, which really has no peak and is used as a basal insulin rate, lasting for almost 30 hours when given subcutaneously. When we talk about anesthetic considerations in the diabetic patient, we need to bear in mind that it's not the diabetes itself that causes problems for us. It's all of the associated organ damage that results from the diabetes. So preoperatively, we may want to look at the patient's hemoglobin A1C, which gives us a good idea of what their average blood sugar has been over the past 3 months, and actually correlates very well with the rate of diabetes-related complications. Preoperatively, we want to know what insulin the patient has taken recently and when they took it, as well as any oral hypoglycemic agents. Patients with diabetes commonly have many different end organ diseases. These include coronary disease, bearing in mind that diabetics have an increased incidence of silent myocardial infarction and silent ischemia. These patients may have peripheral vascular disease, cerebrovascular disease, renal disease. They may have autonomic dysfunction, gastroparesis, and diabetic retinopathy. A large percentage of diabetic patients may actually have a difficult airway upon laryngoscopy due to diabetic stiff joint syndrome. The autonomic dysfunction, probably due to some form of neuropathy, can lead patients to become hypothermic and hypotensive in the operating room. When positioning patients with diabetes, we also consider their neuropathy, which can lead to a higher incidence of postoperative neuropathy or ischemia in a limb due to vascular compromise. When using regional anesthesia in a diabetic patient, we should be aware of the increased risk for nerve injury. Diabetic patients are also at increased risk for infection, and so we should be meticulously careful with sterile technique and proper dosing of perioperative antibiotics. There used to be some sentiment that beta antagonists were inappropriate for diabetics, but there's no data to demonstrate that beta blockers will cause hyperglycemia in these patients. Now, the perioperative period is definitely associated with insulin hyposecretion and increased insulin resistance. So we do see some degree of hyperglycemia during the perioperative period. And we know that this is associated with worse outcomes, a very large increased risk of in-hospital mortality, longer length of stay, increased risk of infection, and increased incidence of subsequent nursing home care. So we do have a responsibility to maintain appropriate blood glucose control in the perioperative period. Improved outcomes have been shown with tight blood glucose control, defined as a range of 150 to 200, using intensive insulin therapy. And this has been shown in both ICU and cardiac patients, with a significantly reduced long-term mortality. On the other hand, it's important to know that worse outcomes were shown when the target was very tight blood glucose control, that is less than 110, in cardiac patients. And the worst outcomes were primarily due to hypoglycemia. According to Barish, until the results of current trials are available, it seems prudent to maintain glucose levels less than 180, especially in the perioperative period, and this is in reference to non-cardiac surgery. Once again, I recommend that you follow a protocol as described above. And once again, we recommend that type 1 diabetics who always require some insulin should have 1/2 to 2/3 of their intermediate or long-acting insulin on the evening or morning of surgery. If they're inpatients, an insulin infusion would be appropriate. We should then follow their blood glucose and treat them using an insulin sliding scale when needed, considering not only the value of the blood glucose, but the rate of change. Remember also that especially type 1 diabetics may need a D5 infusion and may need potassium. An important clinical question arises when patients present with significant hyperglycemia. Stolting says that in major surgery, when serum glucose is greater than 270, the surgery should be delayed while rapid control is achieved with intravenous insulin. He goes on to say that when serum glucose is greater than 400, the surgery should be postponed while the metabolic state is restabilized. I would add that in a type 1 diabetic, you might want to consider checking the urine or the blood for ketones to rule out diabetic ketoacidosis. Let's pause here for just a moment in case you have any questions. You can make a note of them and bring them to class, or feel free to drop me an email and we can discuss them ahead of time. Now we're going to talk a little bit more about diabetic ketoacidosis, which is a syndrome that involves breakdown of fatty acids together with dehydration from osmotic diuresis due to significant hyperglycemia, and often associated with nausea and vomiting. In diabetic ketoacidosis, the patient is unable to use glucose because of a lack of insulin. And so therefore they undergo lipolysis and they break down fatty acids to make ketones. Now, only small amounts of insulin are required to block lipolysis, but in a type 1 diabetic who has no insulin, this process goes out of control and they go into ketoacidosis. So therefore, healthy people, even who eat an ultra low carb diet and are ketotic, will not go into ketoacidosis. Theoretically, the same should be true for type 2 diabetics, who do have some amount of insulin on board. However, we do see that a subset of type 2 diabetics are able to go into ketoacidosis, and this usually happens when there's a precipitating event like sepsis or infection. Remember that the ketones made by lipolysis are acetoacetate, acetone, and beta-hydroxybutyrate, and DKA is an anion gap metabolic acidosis. I've emphasized the point that the degree of hyperglycemia does not correlate with the severity of the acidosis. And in fact, patients can present in DKA with only moderately elevated blood glucoses in the 300s. Bear in mind that patients in DKA are often very dehydrated, with a fluid deficit of 4 to even 10 liters, and this is due to the osmotic diuresis as well as the nausea and vomiting. Other signs of DKA would include leukocytosis, abdominal pain, and ileus. The treatment for DKA starts with fluids, electrolytes, and insulin. Once blood glucose comes below 250, glucose is typically added. Potassium needs to be repleted because even though they have a serum hyperkalemia, they usually have total body hypokalemia. And as the insulin goes in, potassium will move to the cells and potassium supplementation will be needed. Urine output should be maintained. Recall that sodium levels on the serum chemistries will be incorrect because they need to be corrected due to the hyperglycemia. And for every 100 milligrams per deciliter that the blood glucose is over 100, you need to correct the sodium by 1.5 to 2 milliequivalents per deciliter. Typically, bicarbonate is not given to these patients, even though they can be very acidotic, because we worry about worsening intracellular acidosis, as well as increasing their hyperosmolarity and shifting the oxyhemoglobin dissociation curve to the left. Also bear in mind that patients with DKA may have concurrent lactic or alcoholic acidosis that should be identified and treated separately. Now we need to contrast this with HNKC, hyperosmotic non-ketotic coma. This usually occurs in type 2 diabetics and is associated with extremely high blood glucose of often greater than 600 and even sometimes as high as 1,000. The patients have enough insulin to prevent ketosis, and these patients usually have higher blood glucose and are even more dehydrated than patients in DKA. They can become very hypotensive and develop lactic acidosis, and can develop cerebral edema leading to coma and seizures. Thrombosis can occur due to the combination of hypovolemia, hypotension, and hyperviscosity. And the treatment is slow rehydration and small doses of insulin, leading to a slower correction that often occurs over a period of more than 24 hours. On the other end of the spectrum, we should think about hypoglycemia, which may be defined as a blood glucose of less than 40 to 50 milligrams per deciliter. But we know that diabetics often have symptoms at higher blood glucose levels, depending a lot on what kind of numbers they typically have on an average day. Hypoglycemia can present with irritability, seizures, bradycardia, hypotension, and respiratory failure. But many of these signs are absent in the unconscious patient, and so it can be very difficult, if not impossible, to clinically diagnose hypoglycemia without laboratory values. The treatment for hypoglycemia would be IV dextrose or glucagon. Before we finish talking about diabetes, we should quickly mention some of the oral agents that are used, mostly in the treatment of type 2 diabetics. In the perioperative people, most people hold all oral hypoglycemic agents, although data to back this up is actually lacking. And in fact, many patients can continue taking their oral hypoglycemic agents on the day of surgery, unless a significant interruption of caloric intake is anticipated, as in larger, typically inpatient surgeries, or surgeries involving the GI tract. Some of the main categories of oral hypoglycemic agents include sulfonylureas like glipizide and glyburide, which increase beta cell activity and thus increase insulin secretion. The biguanides like metformin, which inhibit hepatic gluconeogenesis, thus inhibiting the formation of lactic acid into glucose. Theoretically, this could lead to a risk of lactic acidosis, but I don't think there's really any data to show that this is a serious concern with metformin. The TZDs, most commonly pioglitazone, which is actose, decrease insulin resistance at skeletal muscle and adipose tissue, so they seem to work against the very mechanism of type 2 diabetes. And then newer drugs like Januvia, which increase insulin release and decrease hepatic glucose production. That's all we have to say about diabetes for today, and we'll pick up talking to you in class.